Clients always first.
Oh my gosh. She was a random one too, just like popped up.
All right, we are live on YouTube. Now we're gonna try to go live on Facebook. There we go. And are we live on Facebook? It seems like it's trying to go live on Facebook too. There it is. All right. So we are both live on YouTube and Facebook today. It's Wednesday. What date are we? I always forget the date. You know why? It changes every day.
It does.
We're somewhere in June the 10th, right?
Yes, I think that's about right.
We have an interesting guest with us today, Joseph Shoyoye. Joe, all right.
Thank you, Doc. Thank you.
We've helped me too in the past, with performance enhancement and optimization. So we'll talk a little bit about that later. But most importantly today, we want to talk about, he's a pharmacist. We want to talk about the pharmacist. And we all know that a pharmacist fills your prescriptions, but a pharmacist can do so much more. They're clinical consultants. They're really the experts on drugs while nobody else is. And so the purpose of today is really to get the viewer here on what else the pharmacist can help you with. We will talk a little bit about drugs. We probably have different opinions, and that's okay, right? And we'll talk about that, but then we will move on because whether or not I like drugs, most people are on it. And so that's where Joe comes in. He needs to manage them and educate them, and he can do that better than anybody else, than any doctor does. And that's really what we want to talk about today. So before we get started, Joe, tell us a little bit about your background and also what inspired you to become a pharmacist.
Well, thank you for having me, Dr. Mike, on the show. I really appreciate it. I come from the humble beginnings of Lagos, Nigeria. So I'm Nigerian, and I came to the States when I was 3. So my background has always been very cultured, very disciplined. If you know any Nigerian person, education has always been first. So that wasn't an option for me, right? I had to go to school. So coming from that type of background, I was able to matriculate my way through school. I have over 15 years of experience in pharmacy. So I started off as a pharmacy technician. And as I developed into my trade here, I realized my passion was for people. And my first opportunity I had in pharmacy was as a technician. And the total engagement that I had with my patients was my passion to drive me. So as a technician, I wasn't as seasoned, or I didn't have the knowledge to understand medication. But I had an impact with all my patients. They left there feeling better. So that within itself propelled me to go into pharmacy and to pursue that as one of my dreams. So currently, I am the clinical consultant for one pharmacy, and I do a lot of the clinical work for them. I do an extensive array of bioidentical hormone treatment, supplement, nutrition, anything with integrative medicine.
And we're going to talk about that because it's more than just filling prescriptions, right? And so where do you work right now?
I'm currently working at one pharmacy as a consultant for them now. So
one pharmacy, and that's in Palm Coast?
Right in Palm Coast, yeah.
Okay.
I work with them right now. So that's basically what I do with them.
Now, what's your viewpoint in general on using drugs? Because everybody's on it, and we're not going to agree on this topic, but still, we're friends, and we can discuss this for hours, and maybe we'll do that someday,
right.
a more fierce discussion. But what's your viewpoint on drugs?
So there is a place for medication that I truly believe in, as we talk about maintenance and monetizing the therapeutic outcomes. When it comes to medications, it does expedite the outcome for most disease states, right? And I really feel that that's where we focus on with medications, is how can we get this person better in 5 days than we can in 20 days. So when I look at medicine, I see those benefits because we're all about outcome driven right, within the state. So that's where I see the niche of medicine and how it can implement in our daily lifestyle. So that's really my viewpoint with it. I mean, I know. I know.
That's his viewpoint, and that's fine. But wouldn't you agree that medicine are symptom based? So there's a symptom, and a medicine can basically knock out the symptom. But give me one medicine that really addresses the cause of any disease. Because when we put people on medicine, we can expect to be on it until the day they die.
Correct.
All right. So that in itself really shows that it doesn't take care of a problem. It just continues to subdue the symptoms.
Well, I would totally agree with you. We're in a practice where we are trying to manage disease versus treated it. And we can get into the monetary part of it, the political part of it, but there is that game within the whole scope of practice where, you have to be able to treat the patient. But then based off studies, we have studies we have to think about and things of that nature. So yeah, you're right. Medication does manage, but if you get that one cure-all pill, then we might be in trouble. I don't know what you think.
Well, I think we agree on a lot of things, and that's why you're here too, of course, because I believe that if I get in a car accident, if I fall from my roof, if I get shot, which may happen, right? I end up in the emergency room. I hope, they help me there. If I'm in terrible pain, I hope they give me a drug to get out of the pain. Correct. And so I believe there is a place for medicine. In my opinion, it's just emergency room medicine or very short term, because again, it's to manage symptoms, but then we should get off that medicine and we should kind of focus on what's causing these symptoms. And that's where lifestyle change and nutrition and all those steps come in. And obviously, you're an advocate of that also. And that's why we will educate people what else a pharmacist does today. But, the big pharma, drugs were invented in the 1800s, but the big pharma only started really in the 1900s. Yes. And they really monopolized our whole medical system because, our number one, they control the schools. They fund the schools and control the curriculum also. And so when doctors come out, all they really can do is prescribe drugs. They don't talk about nutrition anymore. They don't talk about other therapies anymore. They don't recommend them either. So it's all about drugs. It's certainly monopolized. When we talk about approval of drugs, we know there's 4 stages in the clinical trials. But if you do a little bit of research, you see how those data and reports are often manipulated. Because when we look at drugs that come on the market, up to 50% of them, they do have dangerous side effects, and then many of them are actually pulled off the market, even though they were supposedly safe after all those trials. So that makes you wonder for sure. There's also something that I call, or that is called surrogate endpoint. You probably heard about that. What it means is, I got a good example, and especially because my mother, they put her years ago on cholesterol drugs, statin, and I didn't know because she lives in Belgium. And so she called me weeks or months later with all these numbness in the legs, and she thought it came from her low back. Of course, I couldn't see her. I was just discussing on the phone. So finally, I asked her what else changed. When did it start? What happened during that time? And finally, she said, I also started taking this statin drug because the doctor put me on a cholesterol drug. And obviously, if you read the side effects, this is one of the side effects. So I told her to immediately stop it, and the adverse reactions went away. But when we talk about statin drugs, when I talk about a surrogate endpoint, what I mean is, yes, the statin drugs lower cholesterol, but what does that mean? Okay, because it's never proven that it decreases any cardiovascular event. Actually, to the contrary. Okay, so yes, it does lower cholesterol, but the question is, do we need to lower cholesterol, and how does that affect cardiovascular disease? And it doesn't. Okay. Same with diabetes, and I don't know the problem or whether or not it's a surrogate endpoint, but when we put people on type 2 diabetes drugs, we measure what? Blood sugar levels, glucose. And so everybody on those drugs thinks, hey, this works well, because when they measure it, it lowers. But then the question is, does that affect the insulin, and does that fix the insulin resistant? Yes, there's a correlation between blood glucose and insulin, but it's not measuring that insulin. And it's not doing those things. So there's many things to think about when we talk about drugs. In my whole life, I took one pill. And it was a few years ago. And it was because somebody talked me into it. My headache was so bad. They had an ibuprofen, 800 milligrams. I took it and it didn't work. Okay. But otherwise, I've never taken a drug. Drugs also are what we call dead matter. There's no living a part of it, unlike your vegetables. Correct. And so that matter cannot act. It only can be acted upon. Okay, so when we take it in, our body reacts to it, basically. And that's why we also have many adverse reactions. And a lot of the adverse reactions are the same. We talk about nausea, vomiting, dizziness, lightheadedness, and those types of things, rashes. And those are all expressions or attempts of the body to expel a toxin, okay? When we talk about diuretics, for example, Um, people have swollen ankles. We put them on diuretics. But the question is, why are the ankles swollen? Because the body's holding on to water. So this person most likely is dehydrated. So instead of getting rid of the water, the person should just drink more water. So many times we really have to question what the drug is for and if actually it's doing us a favor or not. But that's what guys like Joe too, even though the doctor prescribes the drug, he's not a drug expert, okay? And so it's people like Joe that really can get into it with you and give you a lot more recommendations on that. Now, tell us a little bit about the difference, because I hear it in my clinic all the time. People are on prescription drugs, they can't afford it, the pharmacist put them on the generic drugs. What are the pros and cons of prescription versus generic?
So you said quite a lot too. Man, that's another podcast, by the way, in regards to the generics and the pathways and how it interacts with the body. Is a really good one. But to keep things on topic here, when you look at brands versus generics, what most people look at is, at the end of the day, the cost. With these big pharmaceutical companies, they're doing their RDAs and the development. They're so invested into this product that within these studies, they get certain definitive outcomes. So when you look at these outcomes, you're looking to, what is my return on investment? So when you put a few billions, millions to these products, you have to almost monetize that. And within that, right, you have to look into the FDA, which I think we need to really look into, that FDA and how they regulate medications, because that's another thing we need to take a look at when it comes to medications, is how are they getting into the economy, and how are we actually, they're being dispensed. So from my perspective is, there is a difference, but it's the equivalent. So we talk about bioequivalencies in pharmacy, where the drug is equivalent to the brand. So when you look at a drug, let's take, for example, statins, right? Where we have this big one called Lipitor, which is a brand name. With all the extensive studies, they have a bioequivalent number, and the generic companies now, once they have the patent, which means they cannot, make a generic with a patent, once that is expired, the generic companies are able to now formulate and provide data to now make the same bioequivalent drug. So the difference between a brand and a generic is just the bioequivalence and how they make it. Because remember, if you're making a brand drug, they're not going to give you the recipe.
No,
so that's the key.
It's patented.
It's patented. So you have to figure out, reverse engineer how they got to that.
And you may be close.
And you're close within on average, studies say on average 5 to 10%. That's your window. So once you provide that information to the FDA, and you can now validate, do your due diligence in regards to ensure that that drug is what it is, because it is the same active ingredient. It's how you formulate it.
Formulation.
The formulation is key to it, whether it's tablet, capsule. So that's what you see. But the drug itself is the same drug that you get from a brand, and that's how you monetize on that.
When I hear patients, some of them, of course, have to go for the generic because it's much cheaper, and they say it works as good as the prescription. And then others say, I need a prescription because I tried the generic and it didn't work for me. Is that something general, or is it just more individual, or is it more drug specific?
So there are 3 ways I look at this when I see a patient that is impacted by generics. Is what was that active drug made with? Most of the time, it's the fillers that can cause that effect, right? Most of the time. And therefore, you get those side effects. Because remember, once you get into the drug and you start looking at brand versus generic, usually they tailor the brand into a little bit more, I call it like the Porsche versus, a Honda, right?
Yeah.
So they want to make sure that brand has the best ingredients. So when you go to the generic perspective of it, their substitution that they might not be as good, right? So those are the things that happen, because I can use one filler here and use a different filler here, but it works totally different. So that's one way to look at it.
Okay.
Secondly, you must look at how the generic, this goes back to the FDA. Most generic companies are not being outsourced. So you have to look at what is the regulating body and how are they looking at their process, because that also is an issue that we can come across. Because you have this 5-10% plus or minus bioequivalent area, you tend to maybe go overshoot or undershoot, and therefore that can cause an issue. But on average, your goal is to be just exact. So that's another way to look at it. And thirdly is we must take a look at a lot of the patients, because we're looking at genomics now, okay? And that is another thing we need to take a look at is the genomics and how it's actually being broken down in the body. So those are the ways, that's how I look at it when I approach a brand versus generic. And a lot of studies are showing now today that if you look back to there was a big lawsuit that happened with one of the big companies in India where it was atorvastatin. And it's a big study. It's this one village guy, he was really into the industry, and he realized that the production of that drug was causing more side effects than it was benefits because of the tainted products that they may have put into it. So there's so much involved in it, but I never would ever question a patient if they feel the generic's not working over a brand because of all that is going on, right?
Yes.
And it's just like getting a bottle of Tylenol from Walmart or whatever other grocery store. You might have a bad bottle of Tylenol, right?
Yeah.
You might have to look into, okay, what's in it? Who's making it? So it's something that it's common in all that we do. It's just now when you start to now consume this physical type of medicine that causes changes in your body, it reacts a lot differently. It's almost magnified versus taking a Tylenol versus taking that.
So the generic still could work very well for the patient, or it could not work, or it could even give different side effects.
Exactly.
And that's where you come in, because people actually usually go to the doctor and the doctor doesn't know, so they're just going to prescribe another one, versus the pharmacist actually could look into it much better and give much better advice. Definitely. Would you agree?
And that's what we do a lot of. I actually change a lot of generics to other manufacturers.
But let's say I go to Publix or CVS, that pharmacist is not going to sit down with me for half an hour, right?
Yeah, they probably won't. They're probably overwhelmed with work.
Yeah.
And that's just the hustle and bustle of the workflow. But that's really, I enjoy doing independent mom and pops because I really can take the time with the patient. That's what we like to do. I mean, that's what I tell people.
Very good. So mom and pop pharmacists, you maybe even schedule a consultation. Do you schedule them?
Absolutely, we do.
Perfect.
We schedule for sure.
So that's where you should go for your drug questions.
Definitely,
okay.
definitely.
I think. What is your take on things like the opioid crisis? Right. We know 60,000-70,000 Americans die of MS Cotton, Oxycontin, those types of drugs. We knew the Purdue Pharma just got a slap on the wrist, and they paid a little fine, but guess what? They're still producing it. So when people come fill those prescriptions, is there anything that you can do or say, or there's nothing legally that you can do because the doctor prescribed them? That's what I was wondering.
So, in practicing pharmacy, you really rely on your regulators. You rely on those who are telling you these drugs are what they are. So when you come in as a pharmacist, you expect this product that I'm going to give this patient to be the right product because you've done your due diligence. It's FDA approved. So the backing is within the government, right? Because they're supposed to do their part to ensure that the processing part is done correctly. So when they come into the pharmacy, right, and we'll look at the opioid crisis, I have realized that it becomes infused in the system. Because once you just think of it as marketing, if I'm marketing certain drugs, you tend to prescribe a certain way. So when I see patients come into the pharmacy, my goal is to make sure that is this patient really, of course, in need of this amount of medication, but also, can I find an alternative? Because with the opioid crisis, they've now put it on the pharmacist to make sure that let's make sure this is the right drug. This is the right diagnosis. The patient needs this right medication. Because in 2007, the study showed that on average, about 11.1 million citizens in the U.S. were taking opioids.
Yes.
In 2007, right?
Yeah.
And we're in 2020. So you can imagine how that has really increased. But what we're seeing too now is not only are these people being prescribed, you have the ones that are taking it illegally or selling it. Yeah. So you have this big case and crises with opioids that really the pharmacist actually sees it. They see the patients coming all the time.
Yeah.
So what we do now is we provide alternatives. There are so many different things now. We can interject too. CBD has been another alternative.
CBD, medical cannabis.
We're looking at IV infusion. So many integrative things that we can actually use your business is
we do all
well.
of those,
so
yes.
I look at that from another perspective. Is let's find alternatives, because there is a need for opioids, but we've now become the norm.
Dependent and the norm. Now let me ask you. In the past, obviously, and maybe still, a doctor writes a prescription and goes to the pharmacist, and the doctor's the boss, it seems like. But then we had these pill mill doctors a while ago that ended up in jail.
Yes.
And so prescribing these drugs became a lot more stricter, though.
Absolutely.
And so are you saying that when a patient comes with a prescription, even the doctor prescribed it, can a pharmacist deny it?
Absolutely.
Absolutely?
Absolutely.
I didn't know that.
We have a part to do no harm as a pharmacist.
Okay.
Our due diligence part is to ensure it's the right medication, it's the right dose, and it's not going to do no harm, because that pain management doctor may be prescribing the pain medication for that particular patient, but that patient sees other doctors.
Yes.
So we're the gatekeeper. We're the last person that patient
what
sees
else they're on too.
Yeah. And we know exactly what goes on. We can tell you what interacts with one another, and we can tell you, hey, you're taking this for your pain doctor, but your chiropractor gave you this pain medication, or your primary care doctor gave you this. Why are you taking all these medications for?
Yes.
So now we can say you don't need all these medications because you're taking one.
So you can override the doctor.
We can override the doctor.
Do you have to call them and inform them that you're not going to fill that prescription? I'm just wondering.
We don't have to, because every practice is different.
But as a courtesy,
we do call and we validate, because you have to ensure that you have a patient-doctor relationship and ensure that it's validated. So we do call, and if we feel uncomfortable with the doctor's reasoning, we as a pharmacist can deny that patient from getting the drug at our pharmacy. Don't mean it can go elsewhere, but that's what it's supposed to be.
So a pharmacist as yourself that really does care about the welfare of patients would then obviously not prescribe that drug, but at the same time would find alternatives for that patient and consult with the patient if they're open to it.
Correct. And then if they're open to it, we can talk to the doctor. Hey, doctor, have we tried this?
Or medical marijuana or CBD or those types of things.
That's in the conversation as well. And I think that's where we have to break that barrier. And don't get me wrong, and with this opioid crisis, there are a lot of pushback from the doctors. There are a lot of pushback from the pharmacists, because we have to have that conversation.
Yeah.
And I think when we look at our roles, as a pharmacist, I'm not trying to step over your toes and diagnose. I'm just here to ensure that the medication is what's right for the patient. So as we learn to communicate from that area, I guarantee we will curb this crisis, because the communication has to be there. I'm here to protect you and the patient. At the end of the day, the patient comes to see me. So we need to look at it as more of a team effort.
Sure.
Not I am the boss, you're the boss. No, we're working together for this.
Communication would be best.
And that's key. And you're right. We get a lot of pushback.
Yeah.
But we have to make that conversation, because now
I'm glad.
No longer the doctors.
I didn't even know that. Yeah. So I'm happy for the viewers, because the pharmacist has so many other tasks to fulfill and can help the patient in so many other ways.
Absolutely.
Because especially in the opioid crisis, I don't think it's easy, because a lot of those people that have been on it, they're addicted, right?
Yes.
And so that's going to be hard to talk them out of it.
Yeah, it is. And you're getting to mention that now, doctors, these patients are getting very smart. Just I'll let you know, they're very smart about how they go about wording things and getting these medications. So looking at the doctor too, they're just as vulnerable as we are, right? Because it's like,
they could be liable.
They could be liable. So it's like, doctors are learning too now how to communicate with these patients, because you don't want to be in a situation where you have this patient now, forcing your hand. And with the way healthcare is set up, a patient can literally force your hand on how you prescribe. Not saying doctors are doing that, but when you're looking
they can be influenced.
They can be influenced a lot, because you're looking into networks. So when you start to decrease your patient numbers, and they're saying don't go to that doctor,
then they lose Blue Cross Blue Shield or whomever.
You see, so that's what happens.
Doctors are still puppets on a string when it comes to healthcare, because they're controlled by the insurance companies and by the drug companies.
And then we're the ones like, okay, yes.
Yeah, what do we do?
Yes, we have to give it to you, right? But we need to make that collective.
And that's what we really want to bring here to the table today is, don't forget your pharmacist. He's kind of the outstander. And if the pharmacist does care about you, he can kind of be the communication between those different doctors and things and that. And really help you with alternatives, understanding the drugs. before we get into you being a drug expert, let's talk a little bit, because we're still supposedly in this pandemic.
Yes, we are.
I have always a big smile when I say that, because it starts to look more and more, even though people like me said it a long time ago, it seems to be more of a hoax. Not that it's not real,
right.
but the data and the numbers come down and down and down and down. And it seems though, of course, people die from it, but so do they of the regular flu. That it's only the older ones, the ones that are immunocompromised, etc. And still, from the fake news and the media, we see that, we're not giving up on this, because we still need to come up with this vaccine somehow to prevent something that's already dying out. The other day, I think it was Fox News. It doesn't matter. They're all fake, whether it's CNN or Fox News. They basically are worried because they cannot do the studies on the vaccine, or they can't get enough data because COVID is dying out. I would think that's a good thing, but no, it's not a good thing, because we can't get this vaccine completed now because we don't have enough active cases, right? Yes. So talking, there's a story about the drugs, the hydrochloroquine and things like that. Initially, the medical establishment said, well, it can't work because it's an antibacterial and we're dealing with a virus. So they didn't want to look into it, even though all over the world it said it worked, which is hard to say too, because if if the recovery is 99%, how are you going to say it works, right? Because 99% recovers anyways without